So while Rick connects, let me tell you, Dr. Shunk is the chief of cardiology and professor at UCSF and a VA at San Francisco Medical Center. He's a very, very close friend of ours who we have known and worked together for over or nearly a decade. Is that right? I'm not exaggerating?
That's right.
Nearly a decade, and he still talks to us and answers our calls. So this goes to say how much he likes us. So Rick, it's a pleasure to have you again, flying in from San Francisco. Eager to hear how you answer Mazen's very important question.
Thank you very much, Subhash. I think I got a couple of promotions in that introduction, but yes, I really do appreciate being invited to this meeting. It's a fantastic meeting. I think this session has been very stimulating. Oh, I'm on that one. I'm not on that one. Okay. So my assigned topic, I think it shifted a little bit, but I'm supposed to talk about indications and when to use support. I'll have to say, okay. So I have a few disclosures. I have some industry disclosures in the brochure as well that aren't particularly relevant to this, but they're listed in there. The main disclosure is that I'm an employee of the federal government, so I'm supposed to say, as are you, Subhash and Manas and Sunil, that the views expressed here do not represent the views of the federal government. Also, I'm not here to read the IFU to you. You can read the IFU somewhere else. I'm not going to recite that. I'm going to try to discuss how I personally navigate some of the competing considerations that come up in these patients. And so no one has seen or reviewed or approved this presentation. It's just my own sort of ramblings. And my approach might not be exactly right for you. I think hopefully from the other speakers we get a sense. So this is where I work. This is the San Francisco VA. And right behind it is the San Francisco Bay, which are, places that are fun to work and to play. So you might recognize this person in the middle of the picture. This is myself and my colleague Jeff Zimmett with the white coat, and the guy in the middle is Eric Fu, who trained here with Subhash and Manos and then came to San Francisco and completed his training with us. So I thought you'd appreciate that. Great place to work. It's also a great place to play, and just going back to my disclosures about whether my approach might not be right for you, I'll just point out that the bay you see behind the medical center there, I consider it a fun day when I can go out into the middle of the bay with some like-minded individuals and jump out of a perfectly good boat and swim to the shore. So that's what I like to do, and so take that for what it's worth. So when do we consider support? Well, first we've heard discussion about the shock patients, the salvage patients, salvage being patients who've had CPR, huge predictor for bad outcomes. As a bridge to advanced therapies such as destination VADs or orthotopic heart transplant, those are times to consider support. As an operator or as sites that might be putting these in and transferring them or whatever, these are not necessarily the best cases to start out and learn how to use the device, especially for the staff and everything. Things have to move very quickly in acute STEMIs and so on. And one thing that's, I think, fortunate for our setting, in that sense, we're a training center for fellows, is that we don't see a whole lot of these cases, I have to say. It sounds like they see more of them in Iowa and other places. Our patients tend to be more urgent inpatient transfers and elective. So we've developed sort of a sense of this frail heart picture where we start to think about support. So these are patients with low EF and kind of a low resting blood pressure, perhaps not quite shocked, but you know the patients I'm talking about. They don't have any reserve, so they may have a little relative resting tachycardia, low blood pressure, low EF. And then the territory is very important. I think that was a great case that was shown, that Mazen showed, of opening the right coronary to facilitate being able to do a left main and LAD without support. I think that's a tremendous example of how you can make a case safer. But it's the ones who have, a territory like a left main with the right occluded, that sort of thing, where you want to really think about it. And then for us also, the surgical turndowns. Surgeons have become conscious of their report cards and so on. The patients who are unable to be discharged from the hospital. They just keep having recurrent angina, can't get someone to operate, can't manage them medically, you don't really have a choice. And then I put EMA or early morning awakening. If you find as the interventionalist you're very anxious about this case and you want to be less anxious, you can think about ways to support the case so that you can do things without feeling like the patient's going to expire on you. So when do you want to potentially avoid it? LV thrombus is one of the things, patients with bad EFs, occasionally they'll have LV thrombus on their echo, and that's probably a bad idea to put an Impella, certainly into the ventricle. And then lack of appropriate access. I find that if we have a CTA, it's very helpful. Sometimes we do an angiogram at the time of the cath, or they've had one at another time. Even just a peek at the groin from a prior cath or something is very helpful to plan that. There is, of course, a stepwise learning curve, and there's case selection for everybody, so that on the first cases or the cases where you're learning to do this, you want to make sure there's adequate access. But then as you get more comfortable, you might consider things like even stenting the iliac in order to create access so that you can place an Impella and support your case, or go from the wrist. Haven't quite done Impella from the wrist, but you have to have an iliac at the time. And then, of course, this relates to the learning curve thing, but I think that it's been emphasized how getting these things out as soon as they're not needed anymore is important. I'm a firm believer in that, especially for the patients that are sort of elective cases to support you through a tough elective case. I think it's important to master pre-close, whether you mastered that through peripheral skills or whatever, or to have some other strategy where you can feel very confident in getting in and out of these arteries with 14 French access. So I'm going to show a case here to try to illustrate some of this. This was a 71-year-old man who was with multiple comorbidities who had presented a couple of times. His from an outlying VA. The first time we saw him was in February. Our team, he was transferred for a catheterization. History of diabetes, hypertension, paroxysmal atrial fibrillation. Had a stroke in the past and was found to have an occluded carotid and stenosis on the opposite side. Developed end-stage renal disease, was being put on to hemodialysis at the time. He had obstructive sleep apnea, COPD, lots of comorbidities. And he presented initially back in February and with a non-STEMI, elevated troponin, crescendo symptoms of angina, and underwent a cath. I hope that's projecting okay, but part of it's not just the projection. The images weren't all that great on this patient. This was a colleague of mine did this cath, and you see that there's a long left main. There's some tapering at the distal left main. There's some lumpy, bumpy stuff in the LED and the circ, but it's a little bit hard to see. So in some other views, you start to get a sense there might be, again, some tapering at the distal left main. You start to see there might be a collateral branch going over from an atrial there. You notice the vessels are quivering like atrial fibrillation, and you see, sort of moderate disease here and there, mild to moderate. Some more views here is an areocranial to try to identify the severity of that distal left main and proximal LAD, and it looks, a little bit borderline. And again, you see some collaterals going to the inferior wall, into those. Again, in this view, you see the vessels quivering from the AFib. You see some collaterals to the right, and you see at that proximal LAD, there's a haziness there. There's almost a shelf lesion. And so, this is a really sick guy, lots of comorbidities. Take a couple more pictures, and the distal lesion, you're trying to convince yourself. I love that comment that Sunil made about how the indications should not be dictated by the difficulty of the procedure. And I think sometimes even the angiographic reads are sometimes influenced by how sick the patient is and how reluctant we might be to do something for him. But at any rate, I think it's fair enough to say that lesion was somewhat indeterminate. And the right coronary, as we suspected from the presence of collaterals, was occluded. So we have a sort of indeterminate left main with an occluded right coronary. So again, there's the sketch drawing that was done by the team at the time that did the cath, and they decided to call that a 40 to 50% left main, sort of the hedge right in between, with occluded right, and decided to do optimal medical therapy for this guy who was, high risk for surgery. So he went back to where he lives, and 8 months later, he had another non-STEMI. He had recurrent symptoms, similar crescendo angina, and he came back to the cath lab again. So on the follow-up cath, very, very similar, but on some of the views it looked like it was easier to say that that was truly a shelf in the left main, particularly these last. So distal left main and prox LAD were red. This was a different cardiologist who thought that they were more severe than, or had progressed potentially. And with the presence of worsening symptoms and again an enzyme bump, it was felt that that was significant. So he was then referred, as I said, the other cardiologist at the outside hospital called it a 90%. I think, different views, probably got worse. And the CTO of the right, and he was referred for bypass surgery. And I think, targets were pretty good and so on, but here I just copied the note essentially and removed a couple identifiers. And I'm just highlighting, this is from the surgeon who saw him, and basically said he has numerous comorbidities, of course, and found him, despite good targets, he seemed unsuitable for CABG. And the kicker was that he was on Plavix, which always turns off the surgeons. And so I love how the surgeon tells us to do PCI. So so I guess that's how the heart team works in the real world. So you got a very sick guy, and I like this example of sort of, it seems like the can gets kicked down and advised us to do something. But that's okay. So we accessed both groins. Here's the left groin shot here, looking for suitability for support, the right groin here. So between these two shots, we figure we can use one of these for impella support. They don't look too bad. So an impella was placed, and you saw in the prior presentations how that's done. I didn't include that here. And this is the first image that we took, which is basically, you see a catheter marker being pulled back. That's an OCT run. So we performed OCT to sort of settle this. How bad was the distal left main and LAD, and how would we have to manage this? This is the OCT run. You've seen these before, I'm sure. You'll notice, sort of up at 12 o'clock, there's some calcium nodules going by. There's some lipid. I'll stop and show you the areas where we did measurements, but we just went past the left main, and then we'll be into the guide catheter. So this is the cross-sectional area measurement in the proximal LAD, and it measures 2.32. I think everyone would agree that is a critical stenosis in the LAD. This is the distal left main. It's 6.09. I don't know what numbers people like to use. Some people use 6, 5.5. Some people use as high as 7, 7.5, 8. It's controversial, but I think most people would agree that's a significant left main. And the important thing was on the pullback, if you saw it when I went by quickly, the plaque is more or less contiguous, straight across. And so our impression at that time was, as I said, the cross-sectional area of the left main was significant at 6.09. LAD was critical at 2.32. It was a contiguous plaque, but as we saw the circumflex on the pullback, there was very little involvement of the osteal circumflex, so it seemed particularly well suited to a crossover technique, so stenting left main to LAD and leaving the circ unstented. So just quickly run through that. This is the ballooning, and again, the thing you often see in these sort of left main frail patients with the right occluded, you inflate in the left main, and often the pulsatility of their blood pressure goes away or diminishes significantly, but they maintain a good mean pressure because of the impella. So it gives you quite a bit of sort of comfort that you don't have to rush through these things. So these are the first inflations. That's the first picture after the balloon inflations. This is just positioning the stent, so this is a long drug-eluting stent that's going to jail off the circumflex, but that's okay, we think. So we deploy the stent, and then we take a couple pictures after the stent, and we decide that we better make the left main portion bigger because we've already seen on OCT how big it is. No left main is really 3.0, so we make that bigger with some post-dilatation. And I'll show you I guess this one won't play, but so that's the final. So we had an acceptable result. We had TIMI-3 flow in the circumflex, didn't feel we need to go into the circ and rescue it or do kissing balloons or anything like that, and did a final OCT to ensure that we had good apposition. Can do a quick wean of the CP Impella. We use CP just because we had both on hand and it got complex, and we just, for whatever reason, decided to just stick with the CP. So then we de-access and tighten up the pre-close sutures, per-close the other side, and the patient's done. It's out, and he can go off to telemetry, get his hemodialysis, and get discharged the following day. I think, so to summarize the case, the CTO of the right coronary definitely raises the risk of a left main PCI. I put this comment in not knowing you were going to show a case to illustrate the point, but sometimes you can do PCI of the right first when appropriate to make it safer to do the left main, and then you should consider support. Intravascular imaging, I think, is also really important in left main PCI. Make sure you've got the struts opposed and you understand where the plaque is. And then when you see that people are playing the kick the can game, you can look to Hemingway for some inspiration. And here's a picture of Hemingway kicking the can. So thank you.